Presenting on behalf of Medicine 2, the Eagle. This is Mr. X, 62 years old male, presented with persistent throat pain for 2.5 years. The pain was insidious in onset, dull to moderate in intensity, and continuous in nature. There is no aggravating or relieving factor. There is no history of hoarseness of voice, difficulty in swallowing, and chronic cough. His past history is a known case of paroxysmal AF and systemic hypertension on regular medication. He's also a known case of, he's also a reformed smoker. The examination wise, all system examination was normal, apart from there is some subcentimetric cervical and axillary adenopathy. Oral cavity examination was normal, tonsils were normal, thyroid was normal, other system examination were normal. This patient with persistent throat pain for almost 2.5 years, he was evaluated multiple places and outside with multiple NPL scopies and endoscopies. However, there is no diagnosis made, and his pain was persisting that even it was disturbing his sleep. So differential etiology is considered for this persistent throat pain where either laryngopharyngeal reflex disease, chronic pharyngotonsillitis, laryngeal neuropathy, chronic irritant secondary to smoke or chemicals, laryngeal esophageal carcinoma, provided the history of smoking, and any structural abnormality. So again, we started our evaluation similar, which we had done outside. We did NPL scopy, gastroscopy, everything turned out to be normal. We did base of skull CT to look for any structural abnormality that incidentally noted to have an elongated styloid process. And this is a X-ray of X-ray maxilla that is showing elongated styloid process. What is the significance of styloid process in this patient is elongated styloid process is associated with Eagle syndrome. So what is Eagle syndrome? It's an abnormality of long styloid process or a stylohyoid chain ossification producing cluster of symptoms like throat pain, odynophagia, facial pain, heaviness, and a lot of other symptoms. The normal approximate size of styloid process is almost 2.5 to 3 centimeter. When it exceeds size of 3 centimeter, can lead to all these symptoms, and the symptom cluster is termed as Eagle syndrome. So the reason for this elongation of styloid process can be secondary to persistence of embryonic cartilagenic outgrowth or calcification of stylohyoid ligament, formation of bone tissue at the insertion of ligament. So this long styloid process can cause compression of adjacent neural elements or can cause inflammatory changes in the tendinous portion of styloid insertion, or it can even irritate the pharyngeal mucosa by direct compression of styloid process, leading to symptoms. So one case report, even this one elderly male presented with right hemiparesis. Angiogram showed there is a non-visualization of internal carotid artery. Even this case report states that persistent long styloid process can lead to compression of internal carotid artery leading to CVA. This is a rare entity. So for diagnosis of Eagle syndrome, investigation we generally prefer is lateral view skull X-ray, CT skull base or orthopontomogram. Management of Eagle syndrome is predominantly medical therapy is the first line of treatment. Even surgical resection of elongated styloid process is considered as a definitive treatment. The medical therapy which we use is analgesic, anticonvulsant, antiprotons, and local infiltration with steroids or long-acting local anesthetic agents. So our patient, we have started him on medical therapy with pregabalin, and he was even offered surgical management, but he want to continue medical therapy. With this, his pain is now better and he's under follow-ups.
Thank you for that presentation. Any comments from the audience?
No, sir, that's just.
He just
52-year-old.
Yes.
Yes, only 2 years.
Yes, 2%.
Was the styloid process compressing or
Ma'am,
something?
imaging is it's not compressing, ma'am.
We haven't found any record.
Yes.
But I'm sure that would be there for some time.
Yes. Can happen. Okay. Yes.
What is the ideal imaging modality to diagnose?
X-ray or CT 3D recon.
Any other comments? If not, we'll move to the last presentation from Medicine 1. Dr.